Hello, everyone. It's Wendy with Mamalates, Women's Wellness on Demand, helping moms get results with online videos, courses, and classes. And I'm here with Brianna Barker. She's the ICAN president. So she's the president of the International Cesarean Awareness Network. And I'm so excited to talk to Brianna today about the work that ICAN's been doing for years. Specifically, we're celebrating International Cesarean Awareness Month. So we're trying to raise awareness around cesarean births, preventing C-sections, recovering from C-sections. And I just am so excited that you're here with us today, Brianna. I just want to start with you and letting you introduce yourself. Tell us, who you are, your position with ICAN, and then a little bit of the history around ICAN, how ICAN started, and what ICAN can offer moms.
Okay. Yes, my name's Brianna Barker. I am the ICAN president currently. I have been with ICAN since 2013-ish. I met Wendy probably briefly in 2016, I think, at the conference. So ICAN is an almost 40-year-old organization. We've been around a long time. It's unfortunate that, we're still so very needed, 40 years later, and it's been an interesting journey on the culture surrounding cesareans and VBACs over that time. It began almost 40 years ago, just around a kitchen table, grassroots women coming together, supporting each other through, experiencing a C-section. And I'm so sorry. Yeah. Lucy, hold on just a second.
Yeah, no problem at all. We all know what that's like. Having kids at home and doing your videos and work can be challenging. So thank you all for holding on and waiting to hear what Brianna has to say.
I'm so sorry.
Don't worry about it. It's fine.
Yes, my colleague Brianna Smith was originally the plan today to be on, and she is out of birth. So I'm jumping in here, but I do have a little one at home, so I apologize if she jumps in. So Esther Zorn and Elizabeth Handler were the founding members of ICAN once upon a time, and they helped each other through their own experiences, and it was difficult to find support for a VBAC at the time. This was in the mid to late 80s. And so
sorry, it's just there might be some people, so a VBAC, just so some people, I don't know how, if people know, but so that's a vaginal birth after cesarean. And I know that ICAN does a lot of work to educate women on planning potentially to have a vaginal birth after they've had a C-section, to sort of debunk the myth of once a C-section, always a C-section. So, right? Okay.
ICAN is very pro the family's choice, and families being fully informed of their options after a cesarean and before a cesarean on, things that may increase or decrease likelihood. So while we do advocate for vaginal birth after cesarean, because there are so many myths, there are so many practices and policies that are not evidence-based surrounding VBAC, we do not assert ourselves into individual choices, and we don't, say VBAC is better. It's very individual, how people weigh risk, how they even have their own histories. And so, we want to get as much education out there. We want people to understand their rights in childbirth, because that's not always understood. I know myself, the concept of saying no to a medical recommendation when I had my first child was not even on my radar. So,
what do you mean by that?
I think that I was 20 years old when I had my first child, and I think it just was not culturally normal to understand the process of childbirth and obstetrical care and maternity care as your doctor will make a recommendation and then ultimately you decide. I had my cesarean for breech, and so the conversation really went, oh, baby's breech, you're having a C-section today. And so, I mean, I didn't even realize that breech vaginal birth happened. I didn't know it was an option. So, you know, I wasn't fully informed, nor did I really make the choice. But yeah, it's interesting when you live through an experience and then you gain more information later, how, you know, that can bring up a lot of feelings.
Oh, absolutely. And I think you're right that a lot of women don't know that they have a choice. That especially if you're, you know, 20 years old, it's your first baby, you have this plan that, you know, you're healthy, it's going to go this certain way. And then you sort of get, you know, stymied, right? And then sometimes it happens before and sometimes it happens after you've had a cesarean. If it's an emergency cesarean birth where like, oh my gosh, what just happened? You know, what just happened? And like you said, you sort of walk into the hospital and you don't relinquish all of your, you know, rights, but you've got, you know, doctors standing over you. You might be like on your back and, you know, supine position in the hospital bed. You know, you're maybe laboring. It's hard to advocate for yourself in that position, especially if you don't have the information.
Right. Yes. And if you don't even have the information that, you know, you do have the right to these certain things, to be fully informed, to be given options of if you do it, this certain intervention or not, then you really don't. I mean, you don't have the right. So I think it's very important that awareness grows. And I mean, because it is a culture, you know, culturally, when I got pregnant, it was basically, okay, you need to research cribs, you need to research, you know, strollers, and like that was mainstream and normal. And so it was like, okay, I can do those things, but we have to change the culture surrounding healthcare choices and maternity care decision making.
Absolutely. Absolutely. So tell me a little bit about what ICAN offers in that regards, in terms of what you have on your website with, you know, research to, you know, peer support and groups and everything.
So ICAN is a peer-to-peer support organization. We hold space for community members to come together and share information. We have chapters in certain areas. They're all volunteer. We're actually an all volunteer organization, top to bottom. And so the chapters hold meetings. And so, of course, we know like this has been a strange time. So we've had a lot more virtual meetings, but traditionally a lot of in-person meetings where sometimes there will be an educational topic. Sometimes there might be a guest speaker. We've had lawyers, physical therapists, counselors, chiropractors, doulas, you know, you name it, because there are so many topics that kind of touch on ICAN's mission. And so then we also have a website where we have education, support, and advocacy information. We have where you can learn how to start a chapter if you don't have one in your area. That was my experience. I didn't have the support that I needed in my area. And so I felt really alone during my VBAC preparation and journey and all of that. And so, you know, I didn't want other people to feel that way. So that was how I got into ICAN leadership. And then we have social media platforms, and in this day and time, I mean, that's a huge deal. So chapters generally have a Facebook group that's a closed group, and those peer-to-peer conversations can happen. You can read other people's experience with a particular provider, say, and see how this provider supported this particular scenario. The search feature is pretty nice for that provider shopping journey. And we receive those requests for support quite often.
So what do you mean by provider shopping when you say that?
Okay. Yeah, so when a person, either before they get pregnant, it could be, just thinking about having another child. Often they think, okay, well, especially if they had a previous birth, this birth went this way and I didn't like this. So in my next birth, I have a different goal. And so they often want to change providers or seek out somebody who will better fit their needs. Because oftentimes after somebody has their first baby, they're better aware of what they actually do need or not. And so it can be daunting because, what do we really have to look at providers? A few vitals.com or, there are some review websites, but you can't always understand where those people were coming from or what their goals were. They may not align with your goals. And so it can be really, really important to communicate, okay, this is my preference. I would like X, Y, and Z. And then so the peers who are answering, they can better answer that question and say, those are my goals as well. And this provider met those needs of mine, or this provider did not. So it creates a more informed decision-making tool for even choosing a provider.
Okay.
Because we know that provider cesarean rates and even hospital cesarean rates are a huge influence to your risk for cesarean.
And people can find they can find the provider's C-section rate online?
Sometimes. Mm-hmm. In my chapter, that is something that we do as leadership, is seek out provider rates. We currently do not have a system that shows their full and current cesarean rate. But what we do have is certain insurance providers will show how many births that were paid for with that insurance were cesarean versus vaginal. And so then you can extrapolate, that cesarean rate. So we publish that with a caveat that, this will be more or less accurate depending on, for instance, if a provider does not take Medicaid, then the bulk of theirs is going to be private pay insurance. And if it happens to be the most popular private pay insurance, then you know that it's a more accurate figure.
Right. So that brings me to the first question I forgot I wanted to ask you. What is the current cesarean rate in the U.S.?
31.7%.
Wow, so that's what it was about 17 years ago when I had my son.
It's been pretty stagnant. Mm-hmm. Yeah, it'll just a couple of points, not whole points, but it's really not moved much over the time that I've been involved in ICAN as well.
Right.
So, we see tools coming out, and it is becoming more discussed among hospital watch groups. Leapfrog is one, but it's a slow movement. They're now publishing rates if they are above a certain threshold, but it's NTSV cesarean rate, which is a head down baby, a singleton baby, a first time mom, and transfer. What's the other one? One head down, full term. It's term. Okay. Yes, a full term baby. So,
well, it's my understanding too that C-section rate is so high because of the repeat C-sections, right? Okay. That if a mom has one the first time, like we were just talking about,
right,
the chances are the provider is going to recommend that she have a repeat.
That's C-section. That's a huge part of it, and that's the NTSV does not look at that at all, and so that's definitely a problem with NTSV, and it's kind of one of my pet peeves when people interchangeably use NTSV cesarean rates with the term low risk cesarean, because I don't feel that's accurate, and I don't think the public understands that. So, and also the rates, I think it's above like 30-something% for the NTSV rates that they're flagging as, this is bad and we're publishing this, which is insanely high.
Right.
I mean, so when you've got that as an NTSV, often it's a 50% plus cesarean rate at a hospital. So,
wow,
we've got a lot of work to do.
Yeah. Well, and I part of my birth plan wasn't having a C-section. So like so many moms, that cesarean happens. It's an emergency cesarean. So then I wasn't prepared when my healthcare provider said, hey, you've been in labor for 37 hours. We're looking at, having a, cesarean birth. And so I just was floored. So I didn't have anything in my back pocket. I didn't have anything as part of my plan, B for my birth plan, let alone like a jump start on, recovery. So what do you tell people that, does ICAN have resources for women that aren't even necessarily planning a cesarean birth, or, that are, I don't know, that's not really on the front of their mind, but they kind of maybe want to have it in their back pocket? Like, what do you have for those women, or tell those women? We
really say that it's a good idea for anybody who is pregnant to have a cesarean birth plan. That's something that we try to get out there. And, we've had a lot of chapters do birth plan meeting topics, and then have resources for that, and kind of walk people through the process of how to decide, how to walk through what you might want or not want, or even what the options are, And so that's been greatly beneficial even to those who have not had a primary C-section, and they just, are wanting to avoid, but also wanting to be prepared, because, I think it's pretty well known that when these kind of things happen and we feel really unprepared for a surgery, that it can be more traumatic. And so we want to avoid that and reduce traumatic births. That's very important. I think we had little PDF pictures for a visual birth plan. And so we had people do like a poster board, and the front of it be their plan A. And then the back, a lot of people kind of split it into even an induction birth plan, because an induction can have different options, and those can impact your risk factors or your comfort levels, or, things like that. So they'd have a plan B, plan C, and, and then it's just there with you. So
at the ready,
in the midst of kind of craziness, you don't have to think through all of that stuff. You've already decided.
Yeah. That's great. So one question that just popped up from Sydney is she is wondering, what are the most common reasons for cesarean births? And I know that, like you were talking about, part of that is that sort of augmentation, right? Like starting sort of stripping the membranes, like starting down that path of intervention can be one of them. But please tell us what else.
So malposition is also a big one, and that would include breech. It's interesting because very often we kind of only hear talked about, is my baby breech or not breech? But there are other positions that can cause various problems. They don't necessarily have to. I gave my first feedback was posterior, which sunny side up, what people discuss, and asynclitic. So he was like, this.
That was mine too.
Gosh. But yeah, it really wasn't discussed enough. So malposition is a big one. And also part of that is the lack of breech skills. So we are losing, especially in America, the training. Doctors are not being trained to do breech vaginal birth.
So when doctors go to medical school, they don't have a training in breech birth. Do you know?
So it has been greatly reduced, is what I'll say. I don't want to make a blanket statement, but it is basically halted. And so then you also don't have people teaching med students, the new doctors coming on, and it gets tricky. So, and ACOG doesn't say, it says that breech vaginal birth can be a reasonable option with a skilled provider. Right. But when nobody is skilled, then you really have mandated surgeries. And that's, A, it's not good to have a mandated surgery. Mm-hmm. B, you're going to have undiagnosed breaches pop up in spontaneous labor. And so it makes birth in general more dangerous.
Right.
If anybody's going to be trained on a higher risk situation, it should be the OBGYN specialist,
So, okay, so malposition, augmentation, reason for C-section. I know the duration. So if you're full term, a lot of times they don't want to go past 40 weeks. That can be one. What else?
So failure to progress. I hate to use the word failure, but that's what often is charted. It can be failure to progress or failure to descend. But one thing that's extremely interesting is that so very often people believe that is what they had when technically they did not. And so you get into really a lot of semantics and well, I had a long labor and my doctor said that, this was not looking like it was going to happen. ACOG put out in 2014 a document for guidelines to safely reduce primary cesareans. Mm-hmm. However, these are kind of protocols that can be looked at in VBACs as well, in my, personal non-medical advice opinion. So, something like you're not even in active labor until you're 6 centimeters. It used to be 4, but they changed that threshold.
Right,
and
I remember that.
A lot of people's history, but they don't even necessarily know that. So, and there were a lot of different recommendations about particular amount of time that before you're in active labor, we shouldn't be expecting cervical dilation that we see in active labor, because you're in kind of that prodromal, slow stuff that can take days.
Right. Especially with your first one, right? Especially with the first one.
Yeah.
So, okay. So then, and then, oh gosh, what was the other one I was thinking about? Well, of course, having had a prior cesarean is another reason that that you would have another cesarean, and then
multiples is one where, and that's another one where some people don't realize that you can have in many situations a vaginal twin birth.
Right. Absolutely.
And there's variations and particulars to that. There are different types of twins, and then the position of the twins. But if you're not trained in breech birth, then that's another. Some providers who are not comfortable with a singleton breech will attend if baby B is breech. That's kind of the more common. It's easier to get support for that presentation, but
that makes sense.
And so, but these are all kind of things that it's not contraindicated necessarily. And then there are obstetric emergencies where vaginal birth is contraindicated, like placenta previa. If your placenta is covering your cervix, it is not safe to have a vaginal birth.
Right. So medical reasons, of course, and we know that can save lives and is absolutely necessary.
Right.
For what we're talking about is more around sort of those emergency or unplanned cesareans.
Right.
So then what about after my son was born, there was sort of or during that time, there was a movement around having more of a family-centered, cesarean. So you're in the hospital, you're birthing your baby, you're surprised that, it's not going as planned, and they're looking at, moving you into the OR for surgery to, get the baby out and move things forward. So what are things that mom can do in that moment to make it more, more of her vision around the birth that she wanted? I know that someone invented these like clear screens so that when they put the sheet up, usually with the surgery, you can't see what's going on, but with the clear screens, you can see your baby. But what else can women do?
So it is, I want to say, it is always good to talk about this stuff early. Even if you're not planning a C-section, just if you're pregnant, have these conversations with your care provider and your hospital. Go on a tour and ask, what do you offer? What are these options? And can you get this? That's kind of how these innovations are carved out in communities for, with people asking questions, saying, I want this. And what do we have to do to get it? If your hospital doesn't have the clear drape, and you do want to see baby, they can lower the screen temporarily and then put it back up. Mm-hmm. And you're not going to see your incision, I want to say, because that comes up a lot.
Yeah.
If you think about a pregnant belly and you're laying flat, you can't see over. So you're not going to see the scary stuff, but you don't have to be the last person in the room to see your baby. That means a lot for a lot of people. Mm-hmm. Skin to skin in the OR is a big one. And that's another one that you really need to talk about before, because often there's going to be kind of a planning aspect to that, with having a nurse kind of be watchful with baby to make sure if mom gets dizzy or, feels sick or something like that, somebody can step in and make sure the baby's safe and that sort of thing.
Or just so depleted. I mean, after I had a 36-hour labor, couldn't eat anything, then had the surgery. I was so out of it. I wasn't even thinking about skin to skin. Sure. So it was so great to have this awesome nurse advocate thinking that for me and just bringing my baby to me,
Sometimes they'll just hold them, there with mom's or the parent's face. Mm-hmm. And, that it can make a big difference. Other things would be not having water cooler discussions at the birth. For some people don't care about that, and it's not upsetting. But I've heard from many people how upsetting it was to kind of hear just people talking about their vacation or their dog.
The providers.
Yes, nurses and that sort of thing during their birth when they're upset, and it just doesn't feel like it's kind of honoring that moment in space. Music, some people want to have their own music, and that could be earbuds or I know they might have something that you could play something, or a Bluetooth. And
I know that one thing that can help too is, two things. I know that for every person that's in the delivery room, it adds like an hour to your labor. Because it's just the more people that are in there, if you've got grandma, mother-in-law, sister, couple of nurses, partner, friend, it just can add to that length of labor, which then, like we talked about earlier, can eventually lead to cesarean birth. And that one way to really help prevent it, a cesarean, is to have that advocate. So to have a birth doula at your side.
I was going to say a doula in the OR is a big one as well.
In the labor. Mm-hmm.
Well, in the
OR too.
With the C-section. Mm-hmm. It's a great thing to have. And I've known women drive 2 hours to have a hospital where their doula could be with them in their C-section, because, it meant a lot for them to have that emotional support, to have somebody that knows what's going on, that knows the processes for the newborn, that help with early breastfeeding and all of that, even take pictures, or, if baby does have to leave and go to the NICU, often your partner or spouse goes with the baby, and you're left by yourself. And that is a terrifying thing for a lot of people.
Right. So having a birth doula, it's someone you have a relationship with. I know oftentimes women go into labor, maybe the OBGYN they were seeing all during their pregnancy or midwife isn't even.
That was my experience. I had never met the OB who was doing major abdominal surgery on me. So that, it's a weird feeling to be in a room of strangers. And so I think it's really grounding. I think that's a grounding point. And delayed cord clamping is an interesting conversation as far as family-centered cesareans. Babies getting all of their cord blood is important to a lot of people, but that can be a more challenging option to get, but it can be done. There are some providers that will milk the cord and not, but I do think that we have data that shows it's not the same. I don't think the exact same benefits happen.
What do you mean by milking the cord?
So they'll kind of run the blood through it, because I think, the time where mom is, the patient is open can increase infection risk. And so I think it's something that needs to be studied more. The idea of a standardized practice for cesareans is kind of being talked about in the obstetrical world, which I find very interesting, especially because physically people's experience with cesarean recovery can vary so much. So I'm fascinated. I would love to see, how was it done really technically? And so what are the techniques that help reduce prolonged pain, reduce, all the negative things? Because like for myself, it was uncomplicated. I had no complications, but I really couldn't walk correctly for 10 weeks, which is, that's pretty long.
Yeah.
And then you hear from other people and it's like, I was fine in a week. I felt great. And I'm just like, how did that happen?
Right. And I think this is perfect because the next is that recovery. And I think so much that's of course, I work with women prenatally and postpartum, but with the recovery, it's really, it is all over the map. And I think for some women, if they have a long labor, 2 or 3 days of labor, I don't know, and then again, like they're not eating because they might have to have surgery and the, hospital says no food. I know some hospitals are changing that now, but, and then you have major abdominal surgery, and then you're, trying to have your milk come in and breastfeed. It's like you are 10 steps behind, right? Yeah. And now you've got this potentially 10-pound baby that you're trying to lift all day long and care for and bend over. So I think you're right. So many factors go into it, right? How much help you have, how big your baby is, what the labor was. But I agree. That's what I found is it's just some women, it's, they feel a few weeks after they feel great. Yeah. And some women it's, years, honestly.
It's all over the map. Yeah. And so, and and we should be looking at, all the factors, if they have help, the stuff after, because I don't think that sort of thing is given enough weight. I remember lugging the car seat around after my C-section. Of course, this was 15 years ago, so I didn't know anything about baby wearing, but it was bizarre. I can just remember it's like, okay, well, everybody's acting like this is okay, so it's okay. I could do this, and I don't think I should have been doing that.
No, exactly. And I remember my plan was I was going to wear my son and carry him on my chest. And he was so long that his feet would kick me like right where my scar was, and it's not that big of a deal. You think, okay, so you can't wear your baby, but like it does, it's just one more thing where you think, oh my God, okay. So then I'm bending down more, and then you're not, getting that connection that you want. So, so that can be really hard. And I know, again, this was a while ago. I know you had yours, a while ago too, but, the protocols, when I left the hospital, I really felt, I was wanting more information about recovery, and I was very surprised that I really had nothing.
Yeah.
And, was sent home on my own, and they basically said, don't do anything for 6 weeks, and then come back at your 6-week checkup. And then as my 6-week checkup, they're like, you're good to go, jump on a trampoline, ride a horse. And I was like, okay, there's a disconnect, because that's a long time, right? During the 6 weeks.
It is a long time. And there was like a viral meme that was going around from some birth worker recently about comparing to knee surgery, comparing a C-section and all the things that they tell you to do, and you get physical therapy and, to support that recovery, to make sure that you're okay. And it's cultural just to be like, it isn't weighed the same as major surgery, but it is. And
it's major surgery, and then that's in your core. So it's really disconnecting your upper and your lower body right when you need it, the most. So I do recommend that all women, before they leave the care of their health care provider, get a prescription for physical therapy, whether it was the easiest birth in the world or, had all kinds of complications, because you might need that a few weeks later. And then if you have to schedule that and get the appointment and get the referral,
right?
Can be
and that's complicated in every state. It's different. Like in mine, I think you can have an evaluation, but you can't be treated without a referral. It's very strange. Yeah. So I wouldn't wait for your provider to suggest it.
Absolutely.
Bring it up.
This is like the theme of this conversation, is you really have to self-advocate, right? You just, and it's okay. Like you're right to, I remember going to an ICAN meeting, and one woman was telling me, she changed providers in like 7.5 months. She changed her provider.
I did at 28 with my third baby.
You changed providers?
Yeah, I did.
Yeah.
And it was scary. And that that's something that gets talked about in our support groups a lot, because I talk about our inner good girl, like our inner, teacher's pet person. And almost all of my friends kind of say, like that is so true, because we don't want to be, annoying or a Karen, but it can lead to injury or we have to prioritize ourselves more, because nobody else is. You have to advocate for yourself. And it was interesting. I actually wrote my provider a letter and read it to him when I left his care, because I felt it was important for him to know the reasons that I was leaving for those people that came after me.
Absolutely. Absolutely. And
I know not everybody will feel comfortable doing that. I'm not saying that everybody should do that, but
no. And on the same, I tell all my moms, I say, you know what, go ask your doctor what you can do after, ask them, what are the exercises? And the more women that come to them and say, hey, what should I expect for my recovery? They're going to feel like they need to have some information or do some research around it, or offer that, to the moms that are coming up behind you. So absolutely. I love that. I love that.
Motivation for continuing education in different arenas, not just what medicines or robotic surgery tools are. I'd love to see OBGYN continuing ed classes and stuff in physiological birth and recovery and emotional support, trauma reduction, all of, it's just, there's so much, not that medicine is not important or surgery, but it's a full picture. I think it's just, that is why obstetrics is complicated, because there's a lot to it. It's not just surgery.
Well, their patient is the baby, right? The mom is like, you're not the patient. Their patient is getting that baby out, right?
Legally, no. But that is it's very interesting you bring that up. There was a recent Harvard Review article on just exactly that, and how that it's not written anywhere, but that's how it's kind of acted on. And so that has sort of flipped the way that providers recommend things, and it's causing harm. and it also makes it where the pregnant people have less. We don't have enough legal precedent to protect the rights that are really there. We do have these rights, but because, of believing or acting as if the baby is the primary patient, what happens is the pregnant person becomes a fetal container, and they aren't valued in the decision making when they are a decisionally capable human being who has the right to make their healthcare decisions that affect their body, their future, and ACOG's ethics committee put out a beautiful piece about refusal of medically recommended treatment in pregnancy. And it's long, but it's great. And it says, they do have the right to refuse medical care, even care that would save a life. I mean, that's their right. And so, but the disconnect with that's the body that puts out guidelines for obstetrics, but we don't see it in practice. And so how do we bridge that gap?
Right. Well, like you said, I mean, advocating, right? Asking the doctors what are their recommendations, for prevention or recovery. So then they're going to feel like they need to have those answers, and it'll just come up more the more we ask.
Yeah. And that's why we have Cesarean Awareness Month, because the more that healthcare consumers have this awareness, they're going to be able to ask those questions, and even know that there is a problem or there are rights that they need to advocate for. So yeah, that's why we definitely we do this work all year long, but we really push in April to make a big jump in our sphere of influence, and we really appreciate this opportunity to talk with you today.
Oh, absolutely. Absolutely. So before we got on, you were telling me about some of the new things that ICAN's offering, and you said you have a toolkit. So will you just tell me a little bit about that? Because I don't know anything about that.
Yeah. So we have a toolkit on our website. If you go to ican-online.org, under the events tab, there's a Cesarean Awareness Month toolkit. So this year we wanted to make sure we had one spot where people could go. We have different sized infographics for each of Instagram, Twitter, and Facebook covers, so that you can help us spread this information with your circles of influence. And that is how, awareness campaigns work. We have all the hashtags that can help people find this information. And we have our key points that we want to kind of get across during this month, and action items like what you can do to help, which include things like, start a fundraiser for ICAN, start a chapter, share on social media, all these things. And we have really handy links where it takes you right to where you need to go. So, I think there's like the Facebook banner things.
The banner or the cover.
So click link and it takes you right there. So, and then while you're there, you can look around the website for, other things. But
people can also donate. I know you have a big donate button too. You have a huge campaign for this month.
Yeah, we have a donate button on the website, and memberships so you can either donate or become a member. And membership of ICAN grants access to our webinars and discounts on certain partner organizations of ours. We send out a newsletter to our members to make sure that you're up to date with ICAN, and say a practice bulletin comes out that we think is super interesting, then we're going to push that out. So both membership and donations help us keep the lights on at ICAN. Volunteers keep us going, but funds keep us, able to be sustainable to do this work. And we appreciate it. Even, every dollar helps. We have ways to do monthly donations, and Facebook is a super handy tool to do fundraising because they waive all the fees for 501c3 nonprofits. So 100% of your donations get to ICAN that way.
Oh, nice.
Yeah, so you can do your own fundraiser. It has, when you push that button, it has your name on it. And so you can do a little bit of your story about why this mission is important to you, or a little bit of your birth history to connect to your friends and family, you know, why this matters to you. And I think that can really make people kind of sit up and be like, oh, wow, you know, that makes a lot of sense because they know you and it's personal. So
right. So then with a mom, you have chapters. That was so valuable to me, surrounding myself with other women and getting support and their knowledge and their wisdom, and really helped me, you know, after when I was pregnant with my second son. So what's the best way if people want to become a member of a chapter? Where can they find a chapter?
So we have on our website, find a chapter. And so there's a handy dandy database. So it is sorted by state. So you'll just go to your state and look through to see, and you may have several in your state. So I'm very bad with geography. So people often, you know, on our Facebook page will be asking for a specific place. I just have like, here, please look at the database. I don't know what's close to what. But, and if you don't see one, there's a link, I believe a link on that page as well, to start one. So if you click the link, then you'll get to go through and see the steps of what that looks like to apply to become a chapter. And we have free training to certify our chapter leaders. It's module based. It makes sure that you know all of the things that it takes to run a chapter, to stay in good standing, and to support your community in a, you know, non-biased way. And so we do our best to make sure that we feel our chapters are the heart of our organization. Facilitating their work is so impactful because, you know, local chapter leaders, they know their area, they know their culture, they know the hospitals and the challenges that are there. And it can be really different from place to place.
That's a really good point.
Yeah. Mm-hmm. So, and even laws in your state, laws about rules and regs on birth centers, laws about home birth midwifery. Up until just a few years ago, home birth midwives were illegal in my state, Alabama. So that's recently changed. And so in our chapter, there have been a lot of people kind of helping each other through what that even looks like in a legal state, you know, because I had to jump the border to have a baby. And so it's just crazy. But yeah, having that space where those discussions are really targeted and you don't have to sort through all the other mommy group stuff. It's like, this is the place, can be really beneficial.
Oh my gosh, so beneficial. It was what got me through. I'm so grateful for ICAN. Really, it was the only resource. Like I said, I left the hospital. I was flipping through all the sample diapers and the formula and all these, you know, sheets of information about I don't know what, and there was nothing.
No, I found my bag from the hospital the other day from like 15 years ago. It was like, I was just like, oh my gosh, this is what they gave me.
Yeah.
Yeah.
The recovery
coupons and
not really what you're looking for when you're physically, you need to recover, right? And then we know that the physical really does affect our mental state. And so like you were talking about, and we talked about at the beginning, you know, so much of the reasons that there are a lot of C-section births have to do with alignment and pelvic alignment, and if there's space for baby to turn, and you know, if they're scrunched together, if there's multiples. So that's a huge piece that I work with prenatally and postpartum, because I think also postpartum it can really be hard if you've had, and this is, I'm speaking from my own experience, but I felt like almost frozen postpartum because I was like, what just happened to me?
Oh yeah.
Physically, I was using my shoulders all the time to lift my child, and because I couldn't connect with my core. And at the beginning, it was fine, but 2 months into it, it was like, it wasn't fine. Right.
Right. But like just even that timeline, knowing what's normal and what is like, yeah, that's not really normal. You should, have some intervention, see somebody. I think, we need more supports at postpartum for moms and access to, the physical therapy meeting that I had, and this was probably 6 years into my chapter leadership, blew me away. I couldn't believe it. It was like, and there's a lot of myths that if you have a C-section, you're going to avoid pelvic floor issues. Not the case.
No.
Because it's all connected, and our abdominals are connected to our pelvic floor, and then our back, and even things like chronic cough can be associated with some of that stuff being out of whack. So I was just like, wow, we need to, growing human and passing it into the world, whatever way, is tough on our bodies, and we need to really honor that.
Absolutely.
And both, it's kind of like in both, like getting active and the exercise and what to do when and what not to do when. But also like immediately after birth, lay down. I remember I felt so good after my third and fourth births, but my midwives were like, get back to bed. Like,
take it easy. Yeah. It'll catch up with you. It'll catch up with you, right? Especially with a couple other children at home. Yeah.
Oh gosh. Yeah.
Oh my gosh, this has been so great, Brianna, to talk with you and to learn more about ICAN. I know it's kind of getting towards the end of the month, but there's still time for people to help raise awareness around ICAN's mission and goals, and raising awareness around cesarean births. So I hope we get some people going to your website and, joining more chapters.
And the website won't explode when it's May 1st. So it'll still be there. And the only thing that will end is our discount to membership. So that will be the rush. But, other than that, and just our pointed campaigns for Cesarean Awareness Month. But, if you're seeing this later on a rewatch, definitely give us a visit. And I'm sure that you can still help grow our awareness, because that's our mission all year long.
Yeah, absolutely. And then if people can't make it to, you said because of COVID, some of your chapter meetings are on Zoom. Is that right?
Yes. Some are Zoom, some Google Meets, a lot of Google Meets, in fact. So, and because of that, we try to get our chapters to share those, especially if they have a big speaker, with our main ICAN Facebook page. So when they share that event, it'll show up on our main page. So you can kind of scroll through and see and watch in different places. I'm glad you brought that up, because also for people who don't have chapters, we do have a big Facebook group that's just in general an ICAN Facebook group where we have peer-to-peer. It's just not specific to one location. But people still do ask location-specific stuff because, there's tens of thousands of people in there that may know. And then we have a main Facebook page that you can follow to catch up on what we're doing and hear announcements and that kind of thing.
Oh, it sounds so great. Thank you so much for all the time and work that you've put into this, Brianna. I know it's a labor of love. So thank you for taking the time out of your busy, family time to visit with us. I really appreciate it.
Well, we're honored to be here.
All right. Well, thank you. Take care. And thank you, everybody, for joining us. And you can catch this on my YouTube page. And I'm going to try and get it over to ICAN's YouTube page as well, or channel, if you missed it and you want to share it with some friends. Have a great day. Thank you so much.
Thank you. Happy Cam. Bye.